If you're having numbness and tingling and it's persisting for 3 or 4 weeks, I would start to get a little concerned because that's not a normal thing. I think one common misconception people have is that pain in the muscles are actually nerve issues, nerve pain. People with the numbness and tingling that does come and go, it'll just go away, or it's not a problem to worry about because it's not always there. That intermittent numbness and tingling, now you can still have injury. This is not a normal thing. You shouldn't just have numbness and tingling just because. It's like people that are aging and they just assume, oh, I'm getting older, therefore I should have pain. Not necessarily so. Get some answers. Don't ignore it. Go find out what's going on. Get the help that you need.
Pain isn't just about one joint, one injury, or one bad day. It's your body asking for attention, and the right guidance can change everything. Welcome back to the Optimal Health Guide. I'm Michael, and I am here with Josh Vance, the Optimal Health Guide. Josh, how are things going this week for you?
They're going well. Yes, it's been a good week so far.
That's good. We oftentimes talk about how pain, gets our attention. And pain isn't the only way that the body communicates. Numbness, tingling, burning, these are other things that we've addressed little by little, and I'm really hoping to take a bit of a deeper dive into it. We're going to be talking about nerves and hearing from you about how to try to tell, the difference about what's going on and how understanding those signals that are going on in the body can really make a big difference. So before we get to that topic today, I'd like to encourage those of you listening in, please consider helping us to be able to shape future episodes. You can go to podcast.vancept.com and you could submit your questions or comments there to be able to help shape future episodes. I would love to encourage you to like, to follow, and to share any of the resources from whatever platform you're watching these on or listening to these on. Any of those actions can be able to help elevate the status of this podcast for others to be able to participate. All right, Josh, here we go. Let's dive in to nerves. Give us just an overview. What role do nerves actually play in the body?
Nerves are critical. So when we're talking about the nervous system, there's several components of it. First, you have the autonomic nervous system. That does a lot of different things. There's both two sides to the autonomic nervous system. There's the sympathetic and there's the parasympathetic. Okay, they are responsible for kind of regulating a lot of things that the body just does naturally. It also helps with the fight or flight response, along with a lot of other things. Okay, now there's also what we call the central nervous system, which is essentially the brain and the spinal cord.
Yep.
And then there's the peripheral nervous system, which would be all the nerves coming off of the spinal cord. Once they're leaving the spinal cord, they're now part of the peripheral nervous system. So the nerves are huge in that they do just about everything for the body. Nerves tell us when we're hot and they tell us when we're cold, and they cause us to sweat. They cause us to shiver. They cause us to be able to feel things. They help they cause us to have strength. You've heard of people breaking their back or whatever, and they could no longer move their legs. Well, that's because you have a insult basically to the central nervous system and the peripheral nervous system potentially.
Wow.
Which has then affected the ability for the nerves to do their function in their role. Okay.
Wow.
So nerves are hugely important.
Yeah.
They give you feedback. They give you awareness of where your body is. They tell you what you feel. If you can't feel things, it's difficult to pick things up because you don't know if you have it. Okay. It makes you move, it gets you up out of bed. Okay.
Yeah.
So there's also protective mechanisms that nerves give you in the sense of feeling, like people that have lost feeling in their butt because of spinal cord injuries. They don't have that protective sensation. And so their skin doesn't know when they need to get up and move. And so they have to be educated to move off their butt periodically to relieve the pressure. Otherwise, they're going to end up with wounds because they don't have that protective sensation. So nerves are critical and do a ton in our body.
Yeah. Well, it really sounds like it. Let me see if I can recap those three categories. So you've got autonomic, you've got central, and then you've got peripheral. All three of these are working together, or because and maybe this is just my lack. The central and peripheral, I could hear how those are interplaying. Autonomic, is that like it's happening automatically, almost subconscious?
Autonomic is more of just your body regulating itself.
Yeah. Okay, gotcha. That's interesting. Yeah, and I can totally see the underscore you're placing there about the importance of it. I know I've heard somebody talk about like, oh, if pain were just to go away, but actually, like those receptors that help us to understand, just like in your example of not having the sensation in your butt, can actually lead to greater problems. And so there's a gift in pain in that sense.
Yeah.
So when we get to numbness and tingling, what is it that's causing that if the nerves are, working or not working correctly?
Usually, numbness and tingling is a response to nerves being at least irritated. We can have numbness and tingling and cause irritation. And that numbness and tingling usually is because of at least some sense of ischemia. Ischemia is lack of blood flow. So when you think of pressure, pressure is the most common cause of nerve injuries. Obviously, you know, traumatic injuries can cause nerve injuries.
Uh-huh.
Stretching injuries can cause nerve injuries in the sense of a significant traction pulling to the nerve, lacerate, penetrating wounds, a lot of other things. But most common is the pressure. And what happens with pressure is you have ischemia to the blood supply to the nerve. That then over time causes injury to the outer part of the nerve generally first. That's called the myelin sheath. And then as that pressure continues over time, then we could potentially get into the axonal kinds of injuries. All right. But the numbness and tingling is
Uh-huh.
most frequently because of compression, but it certainly you can have some irritation that can cause some of those numbness and tinglings. So, yes, we have direct blood flow to the nerves. I mean, it's microvasculature. It's very, very small. Just like you have, your veins, as you can see, and blood going to all your muscles. We also have it to our nerves. So when we're thinking about some of the nerve injuries like polyneuropathies, and there's a multitude of different causes of polyneuropathies, but, frequent cause is diabetes. Well, that is very much an effect of the microvasculature of the nerves being affected due to lack of blood flow. And of course, diabetes affects blood flow to a lot of other things too. So we have injury due to a lot of different things with the diabetes, but, circulation is an important component.
Yeah.
But certainly we can have injury. We can have a demyelinating injury and potentially even an axonal injury, because usually by the time we have compression bad enough to get an axonal injury, we've already got a demyelinating injury also.
Okay. So you've got pain, numbness, and tingling. All of them are communicated by nerves. Am I correct, at least on that part?
Yeah,
Okay. But it's like the nerves are communicating different things going on. The pain might be, hey, stop, this thing is hot, move your hand. But you're getting at the numbness and the tingling are actually pointing back to something potentially being wrong with the nerve itself.
correct.
Wow. Okay. That's blowing my mind. I think I just associated that it was a different form of communication of pain, but you're actually saying this is diagnosing that something is happening at the nerve level. Okay. You also used a term in there. I want you to define polyneuropathy. I think I can figure out what you mean, especially as you use the diabetes as the example, but define that for us to help us to understand that a little bit clearer.
Yeah, neuropathy is basically an injury to nerves, poly meaning many. So when we're looking at polyneuropathies from a perspective of electrophysiology testing, there's a lot of nerves that are injured, and they can be, and there's, a lot of different kinds of polyneuropathies. Some could be primarily axonal, some can be demyelinating primary, there can be mixed combination of the two, can be caused from diabetes, can be caused from metabolic disorders, can be caused from inherited genetic stuff.
Mm,
There's lots of different causes, but yeah, but that's in essence, the polyneuropathy is injury to multiple nerves.
okay. Good. So let's start to get practical. Somebody's experiencing numbness or tingling. When should someone be concerned about those nerve symptoms?
Well, if you're having numbness and tingling and it's persisting for 3 or 4 weeks, I would start to get a little concerned, because that's not a normal thing. We should not have numbness and tingling. You may have done something. You may not have done something, because there's, carpal tunnel is the most common, what we call focal entrapment. In other words, it's being trapped within the wrist, but it's the most common nerve injury in the body.
Mm,
So, you leave it alone, it can get worse. You
yeah.
don't do something, it can get worse. So at least getting an understanding of what may be causing those symptoms, especially if it's been persistent for 4 weeks, And frequently nerve symptoms, and I hear this a lot, they come and go. They aren't always there. They can be constant,
Yeah.
but depending on what kind of a problem we've got, oftentimes it comes and goes. Yeah, I'm really good. And then at night, I feel it. Wakes me up. Numbness and tingling. That would be typical with carpal tunnel. But we can also have numbness tingling in, maybe fourth or fifth digits. It's not always there. It does come and go. If I'm leaning on my elbows, I feel it more. If I'm driving more, I might feel it more with my arm on the dashboard or on the console or whatever. So symptoms aren't always necessarily there, and that doesn't necessarily mean we don't have an injury just because we don't feel it all the time too. So that, obviously numbness and tingling is an important thing. If we are having weakness, progressive weakness, that's potentially a problem, and we could have some nerve injury there. Burning pain, people often with burning in their feet, both feet, sometimes the hands too. That is very likely to be due to a nerve injury. Obviously, if there's some significant loss of function, and there's also nasty diseases out there. Talking about nerves, we're also talking about muscles. So we can have muscle motor or muscle problems in the sense of disease that can then be related to nerves also. So those are important. If we're having weakness or loss of function, especially something that's progressive and fairly rapid, those are important things that we need to look at.
Okay, that's really good. Why is it that nerve problems will sometimes show up kind of far away from the real problem itself?
Well, that's the way the nervous system is designed, in the sense of, especially if we're talking about such as more proximal lesions in the neck from, say, like what we call a radiculopathy. In other words, we have a pinched nerve in the neck, something causing compression in the neck. Well, depending on where that neck, with the nerve that comes from the neck, because they're all coming out of the neck from the central nervous system to the peripheral nervous system. And then they're kind of like the freeway in Los Angeles. There's lots of different fingers going in different places to do different things. Some are going to areas that cause sensation. Some are going to muscles, and they cross and they divide, and then they come together and then they divide. So there's a lot of complexity to it. And it's just the way the nervous system is designed. From the neck, we have the brachial plexus, and then it branches through that. And so you can feel pain in fingers, even though it's coming from the neck. The same thing in the low back. It's designed the same way. We have a complex freeway of nerves starting again from the low back, from the spinal cord, branching out through the lumbosacral plexus, and then branching down into the hips, the legs, the knees, the feet, the ankle, the whole enchilada. So, they start proximal, but then they're moving farther down the leg or the arm. And so that's why we can feel symptoms maybe down in the foot, even though it's actually coming from the low back.
Yeah. What percentage of the work that you do with people do you think comes back to nerve issues? Is this prevalent? Everybody's got it? Or is this, a smaller?
No, not everybody. What percentage of people? I'd say a good 30%, 40% of people probably have some, and it might even be higher, closer to 50%.
Okay. Yeah. So a fair amount of folks then.
It's very common. Very,
Yeah.
very common.
Yeah. So then what are the biggest misconceptions people have about nerve injuries as they come in to visit with you?
Well, I think one common misconception people have is that pain in the muscles are actually nerve issues, nerve pain.
That would be confusing. Yeah.
Yeah, so they can be a little confused. Or you're pushing on something and it's causing pain, and they feel like that, oh, that's the nerve. Well, no, that's the muscle. So that's one misconception. But I think another misconception is like people with the numbness and tingling that does come and go, that it'll just go away, or it's not a problem to worry about because it's not always there. Again, that intermittent numbness and tingling. Now, you can still have injury. It may not be as severe as if it's, constantly there, but you can still have injury, and, you still want to deal with it sooner rather than later. So I would say that's probably one of the biggest misconceptions. I think another one is that nerves don't heal, because they do. Peripheral nerves, if we're looking at spinal cord, when we're looking at lesions of the spinal cord, okay, yes, if we have a complete cord lesion, there's still no way to totally fix that. If we have a peripheral nervous system injury, our body does heal slowly, but it can heal. So there's a lot of different factors that affect that kind of a prognosis, and the recovery takes time, how severe it was, where the location of the injury is, to what it's innervating. Say we're talking about a low back injury at S1, which supplies a lot of your foot muscles and your calf. Well, that's a long ways compared to maybe your C5 in your neck, which, a neck injury that does a lot of shoulder stuff. So the distance also significantly impacts kind of the prognosis overall. And whether or not it's an injury to the myelin or the axons, that can affect the prognosis for sure. Because axonal injuries are going to be much, much, much slower to heal than a demyelinating injury.
Okay. I've referred to your diagnostic testing as like pretty magical. How does it work to help identify nerve problems?
Okay, so with electrodiagnostic testing, or commonly called nerve testing, or EMGs, nerve conduction studies, all that, what it really does is it looks at a couple different components. It's difficult first of all, it's important to understand what a person, their symptoms, because what their symptoms are, along with an evaluation of strength, sensation, reflexes, where their complaint is, all those sorts of things together, that is going to help dictate what makes sense to test. Okay. There's a lot of different diseases and a lot of different things that cause nerve injuries. So it's important to know what is the top few things based on what we've looked at, based on their symptoms, that makes sense.
Yeah.
Okay. So we have to evaluate that. Now, when we're doing the testing, there's two parts, and they're able to look at things from a different perspective. First of all, the nerve conduction study, what we're doing is we're stimulating the nerves, causing a impulse in that nerve mechanically, a depolarization with the stimulator, and then we're recording with electrodes the amount of time it takes to go from point A to point B within a nerve. So we can look at sensory nerves, we can look at motor nerves, both of those in different lengths. Some injuries typically affect a long length of it. Other injuries are more specific and affect certain parts of a nerve. So we can look at segments of a nerve, which the nerve conduction study does very well. It can look at both motor and sensory. Now, it does not do as good of a job at looking at whether or not we have injuries to the axons. Okay, that the gold standard for axonal injury is really the EMG component, which is putting a little pin in the muscle, recording the activity of that muscle at rest and with some contraction too. That's going to help us really identify injuries that are more proximal. For instance, and what I mean by proximal, more in the low back or the neck, for instance. Now, the reason why is because when we're looking at nerve conduction, when we stimulate, we're stimulating super maximally. So we're giving enough intensity to that nerve to get all the axons in it. Well, the problem is as we get closer to the brachial plexus or the lumbosacral plexus, we're not just stimulating one nerve, we're stimulating a bunch of different things.
Okay.
So it's not as practical for that, and it's less comfortable also. So there's a lot of things you can't get with that nerve conduction study more proximally. Okay. So when we're really looking for axonal injury and other components of it, really the EMG comes in play, because that can help identify the different nerve roots. It can also help identify if we have, because it's in the muscle, if we have muscle disease potentially, versus with a nerve conduction study, it will be totally normal if we have a muscle disease and there's several that may show themselves. So really, you got to have both parts put together to have a comprehensive understanding of what's going on. And then when you have that, okay, we have a nerve injury and here's where it's at. Here's how bad it is. Here's what it's affecting. It's affecting the sensory nerve. It's affecting this motor nerve.
Yeah.
It's affecting only the myelin sheath of it, or maybe it's affecting axons too. So now we know a little bit about prognosis, and then that's going to guide the treatment. Okay. So all that is super important to kind of put the puzzle pieces together to know how to treat it and what's appropriate and what's going on.
Yeah, that's good. Okay, so now you're getting clarity through this testing. It's producing all these answers. You know where you're working. You already hit at that leads to the map or the direction that treatment is going to go. Take those ideas and just tell us, how is it helpful to get that right diagnosis before you start the treatment?
Okay, well, if a person is going to surgery, it would be good to know exactly what the problem is.
Yeah.
That's a no-brainer, but it happens. Okay, it happens. Example, someone with numbness and tingling in, say, the thumb, index, finger. Okay. And they have positive MRI findings in the neck. There's a disc bulge and things like that. They go in and have surgery, and that helps fix the disc bulge, but they still have numbness and tingling. Okay. Maybe they didn't have an EMG before. If they did, they would have known, and then come to find out, well, they also had a carpal tunnel. So maybe there was something else going on in the neck. Maybe it needed surgery. Maybe it didn't. Okay. But they definitely have the carpal tunnel. And so that's why they're still having symptoms. Okay. So
That's a big one.
it's important to really understand what's going on, because while we're looking at that, we can see if they have injuries to the nerves coming from the neck too. I've had cases where they had neck injuries on the nerves, as well as injuries both to the median nerve and the ulnar nerve. And they were very complicated because they needed neck surgery. They also needed ulnar nerve surgery and median nerve surgery. But it was overlaying each other, so it was difficult to really know what's coming from what. So EMG was helpful to identify the severity of different things, as well as what was, clinically going on for the surgeons that are then doing the surgery to repair that. So, another common thing, and I before I actually started doing nerve testing, you get a patient coming in, they're having neck pain, they're having numbness and tingling in, say, index middle finger again. Okay.
Okay.
Well, okay, so we're treating it. Maybe they're not getting better. Okay, so then we're scratching our head. Well, why? I think there's a neck injury. Okay. Well, maybe it wasn't. Maybe it was something at the wrist. And so, again, knowing what you're treating specifically early on is very helpful. So it gives you the appropriate care. It leads to potentially quicker outcomes of knowing what's going on. And the other thing is, if someone comes in and they have severe injury, we'll say at the wrist with the carpal tunnel, we can do therapy for a long time. And because of the severity, it's not going to help. They need something more significant than that. And so, why keep treating something that's not going to get better? It's bad for the patient. It's bad for the insurers, and it gives us a bad reputation as clinicians, because, we shouldn't be doing that. We should be able to identify what's going on. The other thing is, it gives you a patient confidence. Okay, we're going to be treating the right thing. We know exactly what's going on. Now let's go fix it.
That's great. Yeah, I can totally see the benefit and power that comes to both you and the patient to be able to understand with clarity, here's what we've got going on. Let's say that somebody's listening to this, Josh, and they're experiencing numbness, tingling, or weakness. What would you want them to hear?
First of all, I would say, listen, this is not a normal thing. You shouldn't just have numbness and tingling just because. It's like people that are aging and they just assume, I'm getting older, therefore I should have pain. Not necessarily so. So get some answers. Don't ignore it. Go find out what's going on. Get the help that you need. I'd love to help you if we could help.
Yeah.
But, get some answers. Find out what's going on. Don't be afraid to find out, because you still have choice of what to do. You don't have to have treatment just because you know what's going on. And it may be something that's very simple and readily treatable without surgery, that is a very conservative treatment can handle. And even with some education and understanding how to manage it, could totally make it go away. So, do something sooner rather than later, rather than waiting and getting worse. I mean, I've had people 7-10 years, numbness and tingling, never done anything. Well, now it's pretty bad, moderate, maybe even severe.
Yeah.
So much better earlier on.
That's great. Great wisdom there. Well, Josh has really laid out for us, the idea that our nerves are constantly communicating with us in a variety of ways. The question is, are you listening to what your nerves are saying? You can learn more at advancept.com. You can also submit more questions if you'd like us to go further into any of these topics at podcast.advancept.com. Until next time, keep moving forward toward optimal health. Thanks, everybody.